Hello and welcome to a lesson on parasitic infectious diseases, specifically focusing on intestinal protozoal infections. My name is Jackson Stewart, and in this lesson we'll focus on how to recognize that somebody likely has a GI parasitic infection, how to diagnose it effectively, and then we'll talk a bit about the clinical pharmacology for the anti-parasitic agents that we have access to in Canada. The most important takeaway from this lesson should be how you can correctly identify that a patient probably has an intestinal parasite. As discussed in our lesson on helminthic infections, many clinicians inappropriately order stool O&Ps for patients who have gastrointestinal illness NOID, probably since if an infectious organism can be identified, they can usually be easily treated, so this seems like low-hanging fruit for primary care clinicians. Today we'll learn to be more thoughtful about when to specifically suspect an intestinal parasite based on patient risk factors and epidemiology, and then decide when deliberately to treat with available options. Remember, as always, to contextualize when learning any infectious organism in the grander scheme of pathogens, parasites being one of the four major groups of infectious organisms, which can itself be broken down into the two groups of endoparasites, either helminths or parasitic worms, or the unicellular protozoans, which we will focus on today, in addition to ectoparasites, which are most troublesome as vectors for bacterial infectious diseases. We divide up the protozoans into three easy-to-remember groups: the intestinal protozoa, the most abundant, but even so including only a few members; the blood protozoa, including Plasmodium and Babesia; and the tissue protozoa, which are much less common. Clinically, although there are many other protozoa that can be found in microbiologic specimens within humans, these are the primary agents of parasitism in these groups. To begin to learn how we can better recognize when we should be thinking of these intestinal protozoa, let's try the following question. Try describing how you might differentiate between the pathogen type, i.e. viral versus bacterial versus parasitic, in a patient with diarrhea via clinical history taking ± physical examination. Pause the video and list what types of things you would be thinking about. To be efficient, be systematic in your approach. In general, there are broad differences between cases of infectious diarrhea depending on the pathogen type. It is these details which help us decide on next steps. Break it down by relationship with time of year, sick contacts and contamination, diarrhea character, and presence of other symptoms. For viral diarrhea, we'd expect it in the winter as an epidemic, especially with sick contacts that might even be outbreak associated. Diarrhea is acute and generally mild to moderate, although it could be severe, and patients may have prodromal viral symptoms. Remember that the most common viruses that cause diarrhea are rotavirus in pediatrics, as well as norovirus or astro or calciviruses in adults. Bacterial diarrhea is not associated with winter epidemics or sick contacts, but commonly patients are noted to develop illness simultaneously, i.e. all eating at the same restaurant and becoming sick at the same time. It is also associated with contaminated food. Diarrhea is acute and can be moderate to severe, ± involve a bloody or mucus component with bacterial diarrhea. The most common bacteria causing that in Canada and in Alberta specifically are Clostridium perfringens and Bacillus cereus. Parasitic diarrhea, on the other hand, classically is non-time of the year related, but more related to travel to other countries where risk factors for food or water contamination are different. Diarrhea is typically chronic or relapsing or remitting with a patient who might be immunocompromised, although we'll describe when patients who are immunocompetent can get GI protozoa. Classically, patients fail to improve with normal treatments of diarrhea if they have a GI protozoa. In general, viral diarrhea is the most common cause of infectious diarrhea in practice, followed by bacterial diarrhea and least commonly protozoal diarrhea, which is a more common cause of actual diarrhea than gastrointestinal helminthic infections. As I said, the most common viral pathogens are norovirus in adults and rotavirus in pediatrics. Bacterial pathogens are most commonly Clostridium perfringens or E. coli, but can include many others, and parasitic causes are much fewer, as we'll discuss. Almost all causes of bacterial and viral diarrhea are self-limiting in 1 to 2 weeks, whereas although many patients may have self-limiting parasitic diarrhea and never know it, some causes can be chronic, so we should learn how to recognize which parasites can cause these long-term recurrent problems. As a brief review of bacterial diarrhea, what is the most common bacterial pathogen associated with bacterial food poisoning in Canada based on national surveillance data? The answer is, of course, Clostridium perfringens, followed closely by Campylobacter. Surprisingly, E. coli is not the most common, but is the third most common cause of hospitalization amongst diarrheal illnesses. So to summarize, when should we go fishing for intestinal protozoa? We are really looking for strange high-risk exposure factors like travel to other countries, exposure to questionable or known contaminated food or a well water supply, or if the diarrheal illness is non-acute and self-limiting, like in a chronic or relapsing remitting diarrhea with other causes ruled out. Still, we may not catch self-limiting parasitic diarrheal illnesses in this way, but this would not have changed our management. As we'll see, there are some protozoa which may show up in a stool O&P which are non-pathogenic, and treatment targeting these pathogens may simply aggravate gastrointestinal illness. So how can we find these protozoa if we suspect them? The stool O&P is the most commonly used technique to look for helminths and GI protozoa, which involves the collection of a stool sample with smear and microscopy, observing for frank worms, ova, or cysts if visible. As you can imagine, the sensitivity is increased by multiple specimens, so if you have good reason to suspect a parasitic infection, multiple samples are justified. A study from Canada in 2012 out of London, Ontario, retrospectively surveyed the use of the stool O&P for parasitic infections, finding, unsurprisingly, that it has low diagnostic yield. This is probably in part due to, first, that these infections are rare in the first place, but also second, that there may be a practice of sending unnecessary stool O&Ps as routine surveillance in patients who may have non-specific GI complaints. Remember, we can probably be better laboratory stewards by being thoughtful prior to ordering a stool O&P to go fishing for hopefully finding an organism. In this lesson, we'll practice thinking deliberately, what exact organisms am I suspicious for? If you can name them and justify them, we can probably order these tests more intelligently and increase our yield. Further, some protozoa will not be identifiable and require extra special staining, so ID would require a special request from the clinician. We'll learn when this could be justified in practice. Let's introduce this point with a practice question. Which of the following pathogens would not be identifiable on a basic stool ova and parasite? Is it Giardia, Entamoeba, Blastocystis, or Cyclospora? Although there are only very few intestinal protozoa to remember, it's useful to divide them into coccidians, which require special staining, and non-coccidians, which can then be split into amoeba or flagellates and other protozoa. Remember that the protozoa which require special staining include Cryptosporidium as well as Cyclo and Isospora species. The non-coccidians are more common causes of diarrhea, in particular Giardia duodenalis as well as Entamoeba histolytica. Importantly, there are many non-coccidians which are non-pathogens, i.e. Entamoeba dispar or Dientamoeba fragilis, which are frequently incidentally found on stool O&P samples, which do not represent a cause of disease. Recognize these organisms so that you know what to do when you flag positive off of these samples. The three primary intestinal protozoa that cause disease are Giardia, Entamoeba histolytica, and Cryptosporidium parvum. Other causes are much more rare, more likely to be self-limiting, and in some cases it is unclear if these organisms are truly pathogens at all. Importantly, it is useful to be able to speak the language from a protozoal microbiology perspective so that when reading on these organisms, you're able to contextualize when these organisms are detectable from a diagnostic perspective, but also to understand when organisms may or may not be treatable by anti-protozoal agents. Protozoa go through life cycles just like helminths, although these are much simpler, either existing as an adult protozoa, usually a trophozoite, which can grow and is able to absorb nutrients from the host and cause disease, and some form of cyst stage. In coccidian parasites, the cyst stage is called the oocyst stage. Both are shed in the feces, and the term sporulation refers to maturation from the cyst stage into the infective adult trophozoite stage or otherwise. For example, Giardia duodenalis is ingested as an infective cyst, which then matures in the GI tract into a trophozoid, which is passed in the stool in addition to cysts, which are able to survive in the soil and water. Cryptosporidium is ingested as an infective oocyst and matures into a trophozoid, and then other forms, including merozoites and gamete-containing forms, which reproduce to form a zygote, which becomes an oocyst, excreted and able to survive in water and food. Trophozoites and cysts can be the diagnostic stage, but humans can only be infected from the ingestion of cyst stages. Amoeba cycles are very similar, ingesting an infective cyst, although amoeba can cause extraintestinal disease, as we'll discuss. Trophozoites mature and are passed in the feces as well as infective cysts. The question is, why diagnose and treat? If most cases are self-limiting, why bother diagnosing and treating these infections? As we'll discuss, not only can we reduce the burden of illness in our patients by providing care, we can sometimes prevent long-term chronic issues and life-threatening disease. Consider this case of a 54-year-old male living in Northwest Territories who presents with chronic diarrhea relapsing and remitting, with belching and a feeling of fullness. After several episodes of visiting physicians to no avail, the patient is recognized to have an intestinal infection with Giardia duodenalis during an unrelated admission. Without treatment, which of the following complications is this patient at the highest risk of developing? The first intestinal protozoal infection we'll discuss is Giardiasis, which is caused by the flagellated protozoa Giardia duodenalis, sometimes also called Giardia lamblia or intestinalis, discovered in 1859 in Prague, although it was one of the first microorganisms identified by the microscope by Antony van Leeuwenhoek in 1681, which he described as animalcules in his stool. Giardia is a problem worldwide. You'll notice that although protozoa sometimes have geographic hotspots, they are more global problems than our helminthic infections. The key to recognizing the risk factor for Giardia is the exposure and access to streams and lakes with wildlife reservoirs. Even water that is used in urban areas, if it is recycled water from streams or lakes, it can be contaminated, and patients have been infected from drinking even from their garden hose. This so-called sylvatic cycle involves animals like beavers, hence the term beaver fever, although beavers are taking the bad rap for all animals who drink from these bodies of water. And it is also the reason why we are unlikely to eradicate Giardia as a human infection anytime soon. Humans may drink from these sources more commonly when they are out of the city and become infected. You can imagine how unclean fruits and vegetables may be contaminated if watered with the contaminated supply, and classically, daycare centers have been known to be centers of outbreaks, since children, especially with diapers, tend to infect each other with fecal-oral spread of disease much more commonly than adults. Once Giardia is ingested, it takes residence in the small intestine, where it lies asymptomatic in 50% of patients, but in the other 50%, a delayed diarrheal illness can occur, probably because of damage that its flagella causes to the villi of the duodenum. Acutely, this can appear 1 week after ingestion, distinguishing this from most bacterial food poisonings as an acute, explosive, foul-smelling watery diarrhea that can be described as frothy or greasy, classically with sulfuric or horrible-smelling belching, which resolves on its own in 1 to 2 weeks maximally. If patients don't auto-infect themselves with poor hygiene, this will go away on its own. Less commonly, patients can be chronically infected and have a relapsing, remitting, recurrent malabsorption problem with steatorrhea, flatulence, and lactase deficiency, which can persist even after clearance. For these reasons, if suspected, Giardia should be treated and suspected in patients with risk exposure history and a malabsorption syndrome. Patients may be more susceptible to Giardia if they have hypogammaglobulinemia, IgA deficiency, or are HIV positive. Diagnosis is obtained via stool O&P visualizing obvious trophozoites or cysts, but fecal enzyme immunoassays and nucleic acid tests are commercially available and effective. Small intestinal biopsies may also reveal the pathogen. Treatment is effective in most patients, 90% who receive cure with simply metronidazole at a dose of 250 mg POTID for 5 days. However, the most important intervention is to prevent reinfection, which involves good hand hygiene as well as boiling or iodinating water supplies if they are likely infected, since Giardia cysts are resistant to chlorination. There are other backup drugs available for Giardia that are rarely required, but might be used in the very rare drug-resistant cases of Giardiasis. So what do we do in these small percentage of cases which don't respond to first-line treatment? Remember our previous discussions. Does treatment failure always mean drug failure? Importantly, we can't test Giardia for in vitro drug susceptibility. No commercial tests are available, and there are no specific genetic markers for resistance. Should we then just assume drug resistance? Although drug resistance has been demonstrated in the lab setting, we should rule out the most common reasons for treatment failure first, the most common being reinfection. We can treat this with metronidazole, but if a patient keeps getting reinfected, no combination of agents will work. This should emphasize better identification of the culprit source. Second, a common scenario is continued diarrhea and malabsorption syndromes post-Giardia, which, as we've stated, can unfortunately be a new chronic problem despite effective treatment. We should be confirming if we think Giardia is still a problem through stool testing to confirm persistence of live trophozoids or cysts. In their absence, trialing a lactose-free diet may help differentiating this from drug failure, but the patient may even have another problem like irritable bowel syndrome. Next, it is hypothesized that some patients get Giardia sequestration in the gallbladder and pancreas, in these sites less metabolically active and perhaps resistant as a source control problem, although clinically we have no action other than to continue treatment attempts. Immunodeficiency, of course, should provide good reason why a patient does not improve quickly with typical treatment regimens. Only after this checklist should we entertain the idea of true drug-resistant giardiasis, since the treatment strategy for this involves giving longer courses of antibiotics, which can be more harmful, and acquiring difficult-to-obtain and more expensive agents. A treatment ladder approach, sort of resembling a trial and error method to treating refractory giardiasis, has been proposed by some authors. You can imagine how it is unknown to what extent all of these patients had a due diligence attempt at identifying and resolving their chief risk factor, or how many simply had delayed resolution plus minus ongoing non-giardial problems. In addition to asymptomatic carriage, all patients were confirmed with stool sample positivity after treatment to be classified as still infected. Regardless, patients who failed 1 to 3 courses of metronidazole were given metronidazole and albendazole, perhaps as local practice, most of them being cured, but others requiring a course of paromomycin, and then finally a combination of higher dose metronidazole and quinacrine to finish off the cohort. This leaves us wondering, being more thoughtful from the infectious diseases perspective, would patients have been better off if they had been given metronidazole 750 mg TID initially? Is the resistance mechanism surmountable by increased dosage? Further, did the quinacrine even do anything? Or maybe did the quinacrine do everything for that last cohort? Since there are no randomized control trials as of 2022 for refractory giardiasis, a suggested approach is one that will have no data comparing to other possibilities, but we can craft something a bit more practical, specifically because in Canada, not all of these options are available, which include agents like albendazole, nitazoxanide, quinacrine, and furazolidone. In particular, we have metronidazole, but the only other agent that we have access to in Canada listed previously as an alternative is paromomycin, which is marketed in Canada for humans, but most pharmacies probably would not have active stock, hence a call ahead of time would be suggested. Although mebendazole is not listed as an available option for refractory giardiasis, mebendazole has been studied and compared to metronidazole for giardiasis in pediatrics, where it obtained a cure rate of 86% in 50 children, compared to 90% in 50 children given metronidazole, judged by success of stool sample clearance. Would we have expected any different if albendazole has some data for use? Practically, we should not be functionally fixed on the tertiary guideline suggestions when practically they don't allow for effective, prompt treatment. Other agents are not only more expensive, but require some considerable effort to obtain, if they are obtainable at all. So practically speaking, how can we go about thinking about treatment for giardiasis? First, we have to emphasize the removal of our source of reinfection for Giardia. If we spend no time determining where our patient acquired the infection, we will always fail to successfully treat our patients. Next, we rule in Giardiasis via stool O&P, visualizing live trophozoites or cysts. And starting treatment could be 250 milligrams of metronidazole for 5 days, which should be more than enough for most patients. Patients who fail to respond but likely have lost their source should be treated with higher doses for longer, 750 for 3 weeks, as a rational first attempt for cost, followed by salvage therapy with added paromomycin or mebendazole as adjunct. Patients who fail these adjuncts could be considered for other agents, although it should be expected that the above strategies would cover most of our patients effectively. So that covers Giardia. Let's move on to our second patient case, a 45-year-old male previously healthy who develops fevers, chills, and abdominal pain for 2 weeks with a recent travel history to India, where the patient drank directly from the Ganges, a river that has religious significance in India but is known to be contaminated with bacteria and parasitic organisms. The patient is found to have a large liver abscess on abdominal CT, and the attending team starts ceftriaxone and draws a blood culture. Our question as infectious diseases clinicians is, which organism is the attending team missing? In this case, hopefully you recognize that this patient likely has an amoebic liver abscess caused by Entamoeba histolytica. Amebiasis is a parasitic infectious disease caused by the amoebic protozoa Entamoeba histolytica var. histolytica, the only relevant pathogenic Entamoeba species. It is more localized to tropical areas and Southeast Asia particularly, with contaminated water supplies in bodies of water which are niduses for recycling fecal-oral spread related to poor hygiene and fecal contaminated water. There is no animal reservoir, and transmission is fecal water oral, but can also be passed human to human via fecal-oral routes as well. Infective cysts are ingested and can cause asymptomatic carriage, patients becoming infectious vectors if they do not practice hand hygiene. If patients develop illness, they develop either an intestinal amebiasis involving a watery diarrhea with cramping, which can be bloody if there are ulcers, which may mimic ulcerative colitis and may even cause the development of an ameboma, which is a granuloma-contained amoebic foci which mimics GI adenocarcinoma and may predispose to secondary bacterial infection and abscess. Rarely, that could present as toxic megacolon or appendicitis as well. But less commonly, patients can develop extraintestinal amebiasis, most commonly as a liver abscess, but also may present as peritonitis, pleural empyema, and less commonly brain abscess or cutaneous and genital lesions. Diagnosis is made via stool, ova, and parasite with serology for extraintestinal disease. Treatment is indicated in all patients and at the very minimum involves use of metronidazole 500 TID for 7 days, which is active against Entamoeba. Reviews on amebiasis also recommend a subsequent intraluminal cyst eradication phase with an intraluminal agent like paromomycin for 7 days, including in asymptomatic carriers. Just like Giardia, Entamoeba is resistant to chlorination, so boiling or iodinating water is the best preventative method. However, I thought this concept of intraluminal extermination of cysts was very interesting. The current dogma from reviews on amebiasis is that metronidazole is only active against trophozoite stages of Entamoeba, and therefore paromomycin is required to prevent relapse from intraluminal cyst carriage. It has been mentioned in some reviews and in Mandel's that there is concern for clinical failure in up to 40 to 60% of patients with metronidazole only. But this number and references to back this up are sparse. I thought, why would this be true for Entamoeba but not for Giardia, which also has a cyst stage? When I looked into the reference chains back through Mandel's to support the claim for needing intraluminal extermination, I only found 3 references used to support the claims, none of which are actually supportive. One article from New England Journal in 2002 supports that paromomycin is effective to cure asymptomatic cyst carriage, but does not claim this improves outcomes when used after metronidazole. Two articles from 1992 in CID using diloxanide or paromomycin just mentioned that there is unacceptably high risk for relapse post-metronidazole and that these agents work for asymptomatic cysts. In an honest summation of the scientific evidence of this problem, there is not enough data to support that intraluminal decontamination with paromomycin after metronidazole is needed or superior to metronidazole alone. Conceivably, however, if patients lose their risk factor, they could have self-limiting illness or be amenable to subsequent metronidazole treatment if, in fact, metronidazole was inactive against cysts. Regardless, we should be critical of dogmatic statements like this in practice. Although this practice is not substantiated by good evidence, it is reasonable to provide treatment in this way, paromomycin being available in some pharmacies with notice. Importantly, paromomycin is the only practical intraluminal agent choice in Canada, the other options being SAP agents and difficult to obtain. Tinidazole is another nitroimidazole option that simply is not as good a choice here in Canada due to difficulty in acquisition. Now moving on to our last practice patient case for the most clinically important GI protozoa, we have a 34-year-old male from West Africa with uncontrolled HIV and a CD4 count of 53 who develops chronic diarrhea in a relapsing remitting pattern and a stool ONP positive with special staining for Cryptosporidium parvum. Despite hygienic practices and nitazoxanide treatment, the patient continues to have abdominal symptoms and continues to shed oocysts in the stool. The question for us is, what is the missing factor in this case? Despite treatment being administered in risk factor resolution, what are we missing? Hopefully you noticed that, of course, the most important part of treating infectious diseases in immunocompromised hosts is fixing their immunodeficiency, if it is reversible, in this case, starting antiretroviral therapy. Cryptosporidiosis is caused by the coccidian protozoa Cryptosporidium parvum, which has two genotypes that infect humans. Geno 2 in particular can be a bovine zoonosis. Cryptosporidium is found worldwide and is predominantly acquired from fecal oral food or water ingestion from contaminated water supplies, specifically when not boiled or iodinated, so probably happens in developing countries more commonly than developed countries. Cryptosporidium can survive for long periods in the aquatic environment, so look for contaminated water exposure in your history taking. Although cryptosporidiosis could theoretically occur in anyone manifesting as a self-limiting diarrhea, which could be confused for simple bacterial or viral gastroenteritis, it more commonly is recognized classically in patients with AIDS, in particular with T-cell deficiency, where patients may have a protracted course with malabsorption syndrome similar to other GI protozoa. Rarely, dissemination occurs and might involve the biliary tree most commonly, followed by the lungs, conjunctiva less commonly, and a rare syndrome involving a reactive arthropathy with Cryptosporidium hominis, which is a human-only pathogen. To recognize this, think of an immunocompromised host with exposure to contaminated well water or supplies close to farm animals. The diagnosis is made with stool ONP with special direct fluorescent antibody staining for coccidian parasites. If you suspect Cryptosporidium, you must specifically request this testing. Treatment is typically not required, however, for most patients, since most patients will have a self-limiting disease even if they're immunocompromised. Remember to reconstitute the immune system and possibly provide nitazoxanide if you can obtain it via SAP for a short course, 3 to 5 days, if severe or protracted. Unfortunately, treatment outcome is poor regardless, possibly due to the disease-specific concerns and lack of immune reconstitution, so teams should be educated accordingly. Failure of nitazoxanide could be salvaged with strange regimens of paromomycin plus minus azithromycin, but generally these regimens fail as well. Now moving on to some less common GI protozoa that cause relevant infection. The grand majority of GI protozoa that cause disease are Giardia, Entamoeba, or Cryptosporidium. Cyclospora chiatinensis and Isospora belli are also coccidian GI protozoa that are classically endemic and tropical foodborne parasites. Think of these GI protozoa when patients have a watery diarrheal illness that might be relapsing or remitting after exposure to vegetables from tropical regions. This can be seen in fresh produce import locally as well, but this is uncommon. Another scenario is travelers who return promptly in the summertime, most commonly in HIV-positive patients. Patients ingest cysts and most usually are asymptomatic, especially those who live at endemic tropical sites. But travelers or immunocompromised patients may develop a watery, sometimes explosive diarrheal illness, which can cause a malabsorption syndrome as well. Interestingly, reactive arthritis has also been reported with these organisms and possibly a Guillain-Barré syndrome. Diagnosis, of course, requires special DFA staining for coccidians, and interestingly, treatment involves giving TMP-SMX for 7 days at typical doses. Immune reconstitution is, of course, always critical. Other salvage regimens may involve ciprofloxacin, but these options are commonly considered to be ineffective. Microsporidia are a group of very interesting protozoal organisms which change very frequently in taxonomy. Most recently, it has been thought that Microsporidia genera are actually protists, in particular protists which are closely related to fungus phylogenetically. As you see, we can in fact use antifungal drugs successfully against them. Microsporidia are rarely specifically identified but include most commonly the species Enterocytozoon bionucii, but several other members as well. They are found worldwide and some genera are possibly carried by wild animals. Essentially, we should consider exposure universal in patients who may have disease related, but in particular AIDS patients with CD4 counts less than 100. Most patients do not develop disease, calling into question whether it is a relevant pathogen or surrogate for a pathogen. But some patients have had reported intestinal disease as watery diarrhea, and some genera have been known to cause specific disease like keratoconjunctivitis and even paranasal sinusitis. Diagnosis is difficult and needs a modified trichrome stain if a relevant sample can be obtained, and treatment should start with immune reconstitution followed possibly by albendazole, although delayed in acquisition, and or itraconazole 400 mg BID for a 2 to 4 week course. Another interesting agent known as Fumagillin, which looks like amphotericin B, can be used topically for keratoconjunctivitis. Balantidiasis is the last common and important GI protozoa to discuss. Balantidium coli is a ciliate protozoa that is also prevalent worldwide, but probably causes more problems in tropical areas, in particular where people keep pigs, since it is a known fecal-oral zoonosis from pigs and monkeys. Fecal contamination of soil or hands leads to cyst ingestion and human infection, where Balantidium establishes infection in the large intestine. Most patients are asymptomatic. It is unknown why some patients develop disease and most don't. But if patients do develop disease, there has been an association with chronic diarrhea and a fulminant dysentery syndrome involving possibly intestinal ulceration and perforation, striking for a GI protozoal infection. Rarely, Balantidium has been isolated from vaginal and GU specimens, as well as the lung, although the clinical relevance is uncertain. Diagnosis is simple with stool, ova, and parasites, and treatment is with doxycycline or tetracycline prototypically for a 10-day course. Although tetracycline may in fact have anti-protozoal activity, we should also consider what we've learned about tetracyclines in helminthic infections, where killing of endosymbiotic Wolbachia species led to anti-helminthic activity. Perhaps with protozoa, symbiotic organisms can be killed, which may have been in fact the primary pathogen or a risk factor for active infection. Like all GI protozoal infections, removal of the risk factor for infection is key, so patients should practice standard hygiene and keep pig sewerage away from human food and water supplies. Lastly, a controversial GI parasite is Blastocystis hominis, which is a stramenophile protist that is found ubiquitously worldwide in the stool of 5% of the general population in developed countries and 40% of the stool samples in developing countries. Interestingly, in these countries, it is more commonly found in the stool of healthy patients. Some reports have demonstrated compelling evidence of disease that resolved with killing of this organism, i.e. a case of Blastocystis parasitemia. But many reports also refute the clinical relevance of Blastocystis. Importantly, it is hypothesized that if Blastocystis is clinically relevant, it is killing of other organisms associated with this organism that may lead to resolution. Many labs even choose deliberately not to report the presence of Blastocystis in the stool, but if clinically it was suspected as a real pathogen, choosing to use metronidazole seems reasonable on first principles, probably as a 2-gram PO single dose. Most patients, however, should not require treatment, and we should deliberately place into clinical context whether a patient likely has a true infection with this organism. So we've reviewed a decent amount of material on GI protozoa. Let's test our knowledge with some review questions. We should focus on knowing when to suspect these GI protozoa specifically. Question 1. When should we suspect microsporidiosis? The right situation could be an immunocompromised patient with AIDS or transplant who has a syndrome like cryptosporidiosis, like a non-resolving diarrhea, particularly if they fail to respond to treatment for cryptosporidia. Possibly think of this as well in a patient who also has keratoconjunctivitis. Question 2. When should we suspect Cycloisosporiasis? This is more specifically a food or vegetable-borne outbreak-related endemic infection to tropics, specifically in a traveler or with imported vegetables, probably more common in the immunocompromised host who develops a relapsing remitting diarrhea and malabsorption syndrome. Question 3. When should we suspect Giardiasis versus intestinal amebiasis? Remember, think of Giardiasis in a patient with watery diarrhea and sulfuric burping with protracted course if access to a sylvatic cycle water supply anywhere on the planet, specifically with a lactase deficiency presentation, whereas amebiasis is typically acquired endemically in tropical or Asian regions with contaminated water supplies and poor sanitation where patients may develop an ulcerative colitis picture plus minus a liver abscess. Question 4. When should we suspect cryptosporidiosis? Just like with microsporidia, a non-resolving diarrhea in an AIDS patient anywhere in the world may be more related to water contamination with farm animals. This could be recognized with a DFA stain. Lastly, when do you suspect Balantidiasis? This is more associated with pig sewerage exposure and contaminated water and food supplies with an acute explosive diarrhea, classically with intestinal ulcer and perforation. Question 6. Which GI protozoa are reliably caught on a typical stool ova and parasite? Remember, our non-coccidians, aka Giardia, Entamoeba, and Balantidium should be caught easily, as well as Blastocystis, whereas Cryptosporidium, Cyclo, and Isospora, and Microsporidia would require special staining. Question 7. Which GI protozoa are endemic and which are ubiquitous? The only really endemic GI protozoa are Entamoeba and Cyclo and Isospora, although Balantidium is much more common in the tropics with pig sewerage. Most others are worldwide ubiquitous. And our last question, 8. What are the sites we have to look for with extra-intestinal spread of intestinal amebiasis? Remember, liver abscess being the most common, as well as peritonitis, pleural space infection, and rarely brain, genital tract, and skin lesions. Now we need to talk about the clinical pharmacology of the anti-parasitic agents we have available for GI protozoal infections. Remember that to be able to organize these agents in our head, we have to also be able to organize our organisms. Although there are several ways to organize and memorize the protozoa for GI infections, practically dividing them up by their phylogeny is less clinically useful than by dividing them up by the diagnostic techniques required or treatment strategies available. We've already divided the parasites by diagnostic technique, where non-coccidians are typically detected successfully by a typical stool ova and parasite, whereas coccidians are not. Interestingly, when you divide the organisms up by which agents we can use to treat them, you can see how the organisms remain roughly in the same groups. The non-coccidians typically being treatable with nitroimidazoles like metronidazole, aka Giardia, Entamoeba, and Balantidium, whereas coccidians typically have unique or specific non-nitroimidazole treatment options. This could be because these organisms are less well studied for therapy, probably true, but also because of unique biology which makes them unlikely to be susceptible to metronidazole. However, as we'll discuss, metronidazole and Nitazoxanide have very similar mechanisms of action. Remember this when avoiding functional fixedness for treatment prescribing for GI protozoa. The most important group of GI anti-parasitic agents are the nitroimidazoles, which could theoretically be broadened, as we'll discuss, to other agents with the critical, highly reactive nitro group, a nitrogen atom bound to 2 oxygen atoms, one via a double bond, which involves nitazoxanide and furazolidone and even nitrofurantone. Nitroimidazoles in particular were derived from a Streptomyces lab in 1950s, where they were found to kill trichomonads but also bacteria accidentally when it assisted a case of bacterial gingivitis. This toxic nitro group is the key, as we'll discuss, being activated by parasites and anaerobic bacteria specifically and not by humans, causing DNA damage. The two agents in this group are metronidazole, much more commonly used worldwide, and a single-dose option, tinidazole, which is SAP in Canada. Metronidazole in particular is very well absorbed, essentially completely bioavailable from the oral route with minimal protein binding, making it very likely that it has excellent compartmental entry. It is actually a prodrug metabolized to 2-hydroxymetronidazole hepatically, and some metabolites are cytochrome P450 2C9 inhibitors. Tinidazole is usually given as a single dose, but it is not unique pharmacokinetically in that respect, probably just done historically since metronidazole can also be given in this way. You may have noticed if you study antimicrobial pharmacology that several antimicrobials have activity across varieties of pathogens, i.e. metronidazole for both bacteria and parasites, nitazoxanide for parasites and viruses, and TMP-SMX for bacteria, parasites, and fungi. I think this is fascinating, and it highlights that there is a deeper layer of complexity occurring at the biological level for antimicrobial activity, and in particular might reveal relationships between organism types and maybe symbiosis. Nitroimidazoles in particular are used for both anaerobic bacteria, interestingly resources claiming nil apparent activity against non-anaerobes, and intestinal GI protozoa specifically. So what is the shared feature? Interestingly, there is a school of thought that GI protozoa in particular are living fossils or remnants of ancient eukaryotes before symbiosis with mitochondria, when eukaryotes were in a predominantly anaerobic earth environment, inhabiting a uniquely anaerobic niche ecologically in the GI tract of animals. In particular, since these organisms lack the organs of oxidative phosphorylation, they end up accumulating pyruvate through glycolysis, but don't possess pyruvate dehydrogenase like we do. Instead, might have acquired an iron-sulfur enzyme through horizontal gene transfer from bacteria called pyruvate ferredoxin oxidoreductase, or POR, which catalyzes the decarboxylation of pyruvate into acetyl-CoA and a carbon dioxide molecule with a ferredoxin radical in the process, which then donates its promoted electron to reduce NAD to NADH as an energy carrier. Fascinatingly, remember that thiamine, or vitamin B1, is a normal cofactor for pyruvate dehydrogenase in humans. Metronidazole structurally actually has a strong homology with vitamin B1, which will be important later. In the presence of metronidazole, metronidazole is reduced instead of the ferredoxin, and this activates metronidazole, allowing it to have a reactive moiety that can cause DNA damage through formation of DNA adducts and axonal swelling. This is probably why metronidazole is so well tolerated in humans for the most part, but toxic to anaerobic bacteria that have POR and these ancient GI protozoa. But think, would this work as well for facultative anaerobes? The answer is yes, of course, if the organism upregulated the production of POR in anaerobic conditions. Consider this for non-strictly anaerobic organisms. Further, as you can imagine, for an organism to be drug resistant to metronidazole, it would have to downregulate POR to not activate the drug and have an alternative method of generating energy in an anaerobic environment. So although it exists, it is uncommon. This mechanism is conserved for nitazoxanide and furazolidone, and consider this when we think of using antibiotics creatively for difficult to treat infections. Metronidazole, as previously stated, is well tolerated in humans for the most part. Patients have noticed black furry tongue, with no better medical term. That can be caused by a variety of things, but drugs in particular, thought to be caused by disruption of the normal bacteria of the mouth, causing lack of antagonism and an overgrowth of certain bacteria and fungi. Dysgeusia and a metallic taste are common with both metronidazole and tinidazole, and rare hypersensitivity syndromes are always possible with drugs, some signal of rare leukopenia, and also possibly with pancreatitis with metronidazole, specifically in the first 30 days. Unsurprisingly, with its mechanism, metronidazole is thought to be carcinogenic in rats. Whenever possible, don't prescribe antibiotics without an excellent indication. Probably the most commonly stated adverse effect of metronidazole is the noted disulfiram-like reaction or antabuse-like reaction when metronidazole is given concomitantly with alcohol. This has even been noticed in a pediatric patient who was on metronidazole and an ethanol-containing prednisone liquid. The reaction is noted by acute onset flushing, tachycardia, and abdominal distension after taking metronidazole, usually within 2 days of starting the drug with alcohol, and can even be bad enough to require an emergency department visit with fluid resuscitation sometimes starting. It is believed that this could be due to aldehyde dehydrogenase inhibition, just like disulfiram, although this is speculative. Interestingly, a recent systematic review in 2020 called into question the veracity of this interaction, since there are many reports of absolutely no reaction when this combination is administered. Regardless, since the reaction has been noted, it is reasonable to avoid the combination if possible, but keep in mind that this reaction might be genetically mediated and is not certain to happen in any given patient. Most importantly, there has been some debate on whether metronidazole causes some form of neurotoxicity, stemming back from the days when it was used in acute tetanus more often, although confounded. Now there is no doubt that metronidazole is firmly associated with a neurotoxicity syndrome, probably that lies on a clinical spectrum of severity and localization that could be called metronidazole-induced encephalopathy, or MIE. The leading hypothesis is related to vitamin B1 deficiency. Remember, metronidazole looks structurally just like vitamin B1, see at the top right, and there have been papers that theorize reduced vitamin B1 absorption similarly to alcohol abuse. Indeed, alcohol abuse and cirrhosis have been identified as risk factors for MIE. Metronidazole metabolites in an anaerobic environment have also been thought to cause direct axonal damage and swelling, leading to these neurotoxic features as well. Some form of MIE has been reported as early as 3 days after initiation and as late as 8 years. From my search, most cases hover around an onset of 30 to 40 days post-metronidazole start. Here is the key. The clinical presentation involves all of, or a combination of, the following classically: cerebellar disease, i.e. ataxia, dysarthria, limb discoordination, and gait disturbance, most commonly in 75% of patients, some form of altered level of consciousness in a third of patients, seizures in 13% of patients, and a polyneuropathy syndrome as well, predominantly a progressive bilateral sensory neuropathy involving bilateral lower limb paresthesias, which may progress to upper extremities and even involve cranial nerves or autonomic nervous system. Most drug toxicities like this are hard to diagnose, but classically, MIE actually has an MRI finding of bilateral T2 hyperdensities in the cerebellar dentate nuclei. Some other localized lesions have been reported, but the clinical milieu plus these MR findings should be enough for the clinical diagnosis of MIE. Immediate cessation is necessary since there is speculation that a degree of this may be irreversible, with precedent in vitamin B1 related Wernicke's encephalopathy, and most patients nearly completely recover starting about 1 week post discontinuation. Some authors state that steroids might provide a better prognosis, but this decision should be left clinically to our neurology colleagues. Keep this syndrome in mind when your patient develops cerebellar symptoms on long-term metronidazole, not typically the case for most GI protozoal infections. We discussed nitazoxanide in our anti-helminthic pharmacology session, but it is important to point out that nitazoxanide also has this reactive nitro moiety instead, attached to a sulfa-nitroimidazole ring. The same mechanism therefore applies, with POR activation and DNA adduct formation, perhaps inhibiting POR instead of causing cell arrest of respiration attempts. Speculatively, this could be the same mechanism for worm infections, although this is incompletely understood. Remember that nitazoxanide is well tolerated outside of a greenish urine discoloration and rare hypersensitivities, and is a small molecule with large protein binding, likely minimal compartmental entry, just based on these features alone. Furazolidone is another agent with a nitrofuran group, probably also having nitroimidazole-like activity, and thus why it is used similarly for Giardiasis in some countries over the counter. This should make you think as the clinical pharmacologist. Could we use nitrofurantoin for these infections? Food for thought. Quinacrine or mepricrine is more commonly known as an older and no longer used anti-malarial drug that has anti-giardial activity, inhibiting a step in the oxidative phosphorylation pathway and succinate oxidation. Quinacrine can cause yellow staining of the skin and also some strange toxic effects like psychosis and delusions, as well as some blood dyscrasia, so is no longer favored. Interestingly, furazolidone is a monoamine oxidase inhibitor, so drug interactions are reasonably a major concern with use. For both agents, most of their pharmacokinetics is unstudied, and so speculation into clinical pharmacology details is clinically unuseful. If these agents are to be used as salvage options in therapy, I would favor clinical monitoring over speculation into compartmental entry. We have a whole category of anti-protozoal agents that are commonly known as intra-luminal agents, the principle being that they are all poorly absorbed from the GI tract, so may be effective options with low toxicity for GI protozoa which are localized, i.e. intestinal amebiasis and giardiasis. Similarly, these agents are believed to be active against the cyst stage of these protozoa, so may have a role as previously stated as follow-up therapy to nitroimidazoles. Paromomycin is an oral aminoglycoside, but the mechanisms of each of the agents is largely unknown, as well as most of the pharmacokinetics, presumably because the assumption from these drug companies was that a negligible amount of the drug is systemically absorbed. We should recall these examples when discussing complex pharmacology with other clinicians. Clinical PK/PD sometimes is not favored routinely with antimicrobials, despite the axiomatic approach to new antibacterials specifically. Iodoquinol in particular has two iodine atoms attached to its core ring structure and may cause some iodine-related hypersensitivity similar to those seen with amiodarone. Iododerma is extremely rare and severe related to a type 4 hypersensitivity reaction to the molecule, but we should be aware of this in the history. Thyroid issues have been reported similarly to amiodarone, probably depending on the baseline status of thyroid function, aka subclinical hypothyroid versus euthyroid to begin with, and rarely peripheral neuropathies and an optic neuritis have been reported with iodoquinol, although the mechanism is unknown. Lastly, we discussed the use of Fumagillin, which is actually probably an antifungal agent for keratoconjunctivitis caused by Microsporidial genera. Fumagillin is actually naturally produced by certain strains of Aspergillus fumigatus. Remember as well, fumigatus produces another toxin called aflatoxin, which may increase the risk of hepatocellular carcinoma. But the mechanism has not been described. Despite that, looking at the structure of Fumagillin, I recognized similarity with amphotericin B for reference on the left. It is conceivable that Fumagillin also inserts itself into the cell wall of fungi or protists and contributes to cell wall disruption from porin insertion. Regardless, not much is known about the molecule at all. Some have reported possible neutropenia, but this is likely confounded, as always, with post-marketing reports. Lastly, Fumagillin given orally for some reason has been associated with osteonecrosis of the jaw when given with bisphosphonates, but this is the case without Fumagillin, so the veracity of this report can't be verified, of course. Remember to always screen your pharmacology when studying for liver toxicity. Most of these agents are probably not liver toxic except for metronidazole, which may be because it is the most commonly used. Metronidazole has been reported, interestingly, to cause a short latency immunoallergic hepatitis, predominantly hepatocellular, that consistently recurs with re-exposure. Metronidazole DILI has been noted to frequently occur in patients with Cockayne syndrome, interestingly, which is a rare autosomal recessive disease form of dwarfism caused by a fatal error in nucleotide excision repair mechanisms. TMP-SMX and azithromycin are also commonly associated with a hepatitis, again due to frequency of use. Most of these agents are probably safe in both breastfeeding and active pregnancy, especially when benefits are high, and the only agents with concerns are TMP-SMX, particularly in the first and third trimesters, as we know, and quinacrine and furazolidone, which just don't have the studies to support safety, but appear to be able to reliably cross the placenta and into the breast milk. So for these agents, we should only use if we have absolutely no other option. So let us review some clinical pharmacology for these GI protozoal infections before we wrap up. Question 1. For which GI protozoa is metronidazole considered effective and first line? Remember, we can use metronidazole for non-coccidians, but it is first line for Giardia, Entamoeba, and Blastocystis in particular. Balantidium coli might be treatable, but tetracycline is typically preferred. Question 2. What is the correct treatment for disseminated cryptosporidiosis? Remember, cryptosporidium is typically self-limiting and does not require treatment, but a patient with disseminated disease likely deserves some form of treatment. At the moment, Nitazoxanide is preferred, and although regimens state 3 to 5 days, a regimen of 1 to 2 weeks might be more reasonable, or at least until there is some clinical improvement. Question 3. What are the major toxicities of metronidazole and what are their mechanisms? Remember, the most commonly stated is the disulfiram-like reaction, which is uncommon, which might be due to aldehyde dehydrogenase inhibition. But more importantly, metronidazole-induced encephalopathy syndrome, which is probably due to thiamine absorption reduction and axonal damage from DNA adduct formation. Question 4. Amongst the intraluminal agents, which are available in Canada? Remember that we only have access to paromomycin easily in Canada. Diloxanide and iodoquinol are theoretically obtainable but would require extra paperwork. Question 5. What is the right scenario for attempting to acquire quinacrine or furazolidone in practice? The only conceivable scenario is with high-dose, longer-course metronidazole failure with combination treatment with paromomycin and mebendazole or nitazoxanide before even trying to obtain quinacrine or furazolidone. Remember that many patients who fit this description may have residual GI disease that is not Giardia related, aka new lactase deficiency or IBS. Rule in disease by visualizing live trophozoids or cysts first. Question 6. What drug is the right treatment for microsporidial keratoconjunctivitis? Remember, it is the Fumagillin-derived topical Fumagillin. Question 7. Which GI protozoal infections are treatable by antifungal drugs and which are treatable by antihelminthic drugs? Microsporidia is treatable by itraconazole, and both Microsporidia and Giardia have evidence for use of benznidazole antihelminthics, aka mebendazole and albendazole, which are microtubule inhibitors and starvation inducers. Question 8. What is the salvage treatment regimen for nitazoxanide failed cryptosporidiosis? Remember to always reconstitute these patients' immune systems if possible, but you could try, with low expectations, a combination of PO, paromomycin, and azithromycin. Our last question, which GI antiprotozoals could cause DILI and which are unsafe in pregnancy? Remember, the agents that probably cause a real DILI are mostly metronidazole, TMPSMX, and azithromycin, probably more well known from frequent use, and only really TMPSMX is truly unsafe in pregnancy, with quinacrine and furazolidone having little data but probably have penetration through the placenta. And with that, we have completed a review of GI protozoal infections, covering the most common and less common GI protozoa that cause human disease, reviewed the clinical scenarios when we should consider these organisms in practice, reviewed the biology and diagnosis of these pathogens, and an in-depth pharmacology run for managing them in practice. Remember to review the differences between coccidians and non-coccidians in diagnosis and the distinct treatment regimens for certain organisms to be able to assist in practice, and review when to reach for the hard-to-acquire drugs instead of being functionally fixed on antiquated tertiary references for uncommon pathogens. Remember, you can't cure GI protozoa or any parasitic infection without control of the source. If you don't break the life cycle and stop exposure, no anti-parasitic treatment regimen will work. Thank you for watching.